Today's topic I have chosen is the examination of knee for the special tests, which is more commonly asked in the active session of the OSCE. Will be asked in the short cases. Externals want to know whether the students can perform the special tests of the knee competently, and it could be a short case, a long case. So we will start it with the Lateral tap test. Prerequisites are knee has to be kept in neutral position, which is extension. You have to milk the suprapatellar pouch empty. Push the patellar down onto the femoral condyle so that it hits the condyles. Feel the patellar tapping on the femoral condyle. When the tap of the patella on the condyle is felt, this is called positive patellar tap test. Then there is a cross fluctuation test. It is applicable only when there is a large volume of the fluid inside the knee. And the procedure is the left hand of the examiner compresses and empties the suprapatellar pouch as it is done in the patellar tap test. And the right hand straddles the front of the joint below the patella. By squeezing with each hand alternately, a fluid impulse between the compartments is transmitted across the joint, and then it is said to be positive. And there is a third test that is called Bulge test. This is useful only when there is very little fluid in the joint and it is not easy to get it right. So after squeezing any fluid out of the suprapatellar pouch, the medial compartment is emptied by pressing on the inner aspect of the joint. That hand is then lifted away and put on the lateral side of the patella, and this part is sharply compressed. A distinct ripple is seen on the flattened medial surface as the fluid is shunted across. This is the Bulge test. So empty the suprapatellar pouch or milking, then empty the medial parapatellar gutter, and then push the fluid from the lateral parapatellar gutter so that it goes in the medial side, and then watch for the bulge on the medial side. You will see the demonstration and the technique how to do it correctly. Tap test. Step 1 is you have to milk the fluid from the suprapatellar bursa. From where you will be milking? From where? Mid thigh, upper thigh, lower thigh. Remember, the suprapatellar bursa extends 3 or 4 finger breadths away from the superior pole of the patella or proximal to the superior pole of the patella. So we will start a little higher than that. And you flex it. Don't allow fluid to go from here or here. Don't allow it. So all around you keep your hands intact. Come closer to the superior pole of the patella and you may little push it so that it goes over the femoral condyles. And then you have to put pressure on the patella, so much pressure that it goes and hits the femoral condyle. Not necessarily with 1 finger or 2 fingers. They are absolutely irrelevant. Whatever force you have, I will do my 5 fingers, no problem. I will push it. 4 fingers, 3 fingers. It should be strong enough that it goes and hits the femoral condyle. And when it hits it and rebounds, that perception is called patellar tap. Next one is cross fluctuation and bulge test. How to do it. So to detect the fluid in the knee, there are 3 prescribed tests. One is the patellar tap test, another is the cross fluctuation test, And the third one is the Bulge test, or also it is called fluid shift test. The cross fluctuation, you have to do the same. I have already done the milking of the suprapatellar pouch. Then keep the two fingers quite away from the swelling, and when I will be pushing the fluid with these two fingers, I will perceive the thrust of the fluid with these two fingers. So it will be here, and when I will push the fluid from here, I will perceive the fluid here. So it will be something like this. It can be elevated also if there is a fluid. So this is called cross fluctuation test that usually you do in a cystic swelling. The third one is fluid shift test. Milking of the suprapatellar pouch is to be done, already done by me. And then what you do is you remove the fluid from one compartment. So I'm removing the fluid from one compartment, and then when you push it again from the other compartment, you can see the fluid refilling in that compartment which you have just emptied, or can see a fluid bulge as well. This is called fluid shift test or bulge test. So these are the tests to detect the fluid in the joint. Then there are certain tests for the ligaments. Anterior draw tests, a very important one. It is done to test the integrity of the anterior cruciate ligament, and it is done first on the normal side, know the normal play of the ACL, and also to give confidence to the patient. Hip is placed 45 degree and the knee at 90-degree flexion. Patient is first asked to relax the hamstring, and it is also felt that the hamstrings are relaxed. Foot is stabilized, and most of the time examiner sits over the foot, and then tibia is stabilized with both hands of the examiner, and then the examiner pulls the tibia forward and see how much the translation of the tibia on. Let us see how it is done for the demonstration, how to do it properly when it is needed. Flexing the knee 90 degrees, stabilize the foot by sitting over it. Now I have stabilized the foot. Considering the right knee is pathological one, I will do it on the left side first. So the first step, flex the knee 90 degrees. Second, stabilize by sitting over the foot of the patient. And third is look for the hamstring relaxation. Remember, if hamstring is not relaxed, it is tight, it is attached over the tibia here. And if you pull the tibia, it won't allow tibia to translate forward unless it is relaxed. If it is not relaxed, give confidence to the patient, ask him to relax it. Ascertain when it is relaxed, catch hold of the upper part of the leg, thumb closer to the joint lines so that you can perceive the movement, and definitely you will be looking at it as well. And then you can pull it. Pulling is of two methods. One is pull it the way I am pulling it with my elbow bent. It should be sustained force in one go. There should be no repeated jerking movements. And the second method is extend your elbow and your body will pull now. So the pull remains constant on both sides. And then you repeat on the other side. On the other side, hamstring relaxed that I am seeing. Catch hold of the tibia on the upper part, thumb closer to the joint line and pull it. It is sustained, forceful pull. And watch for the translation of the tibia over the femur. There is no translation here. It means the ACL is intact. After the anterior cruciate is tested, posterior cruciate is tested by posterior draw tests. Procedure is similar, only difference is that you have to push tibia posteriorly, and let us see how it is done. I am going to demonstrate how to do the anterior and posterior draw test in pathological knee. Knee is flexed, stabilize the foot by sitting over it, identify the normal side, and this one is the abnormal side. So I am going to do the anterior draw test on the normal side, and I cannot draw it, it is negative. And then I will repeat it by pushing backward is the posterior draw test, it is negative. I will do anterior draw test on the pathological knee, and you can see it is coming up, but be very, very careful that it is positive or negative. It is coming up from the sagged position, from the posterior position. There was a sag sign positive in it, and it is coming up to the neutral position. Now, if I bring it to the neutral position and then do the anterior draw test, it won't be positive that I am going to demonstrate. So this is the neutral position I have brought in, and then I am pulling, it is not coming up. But if I am pushing it back, doing the posterior draw test, it is going back. It means the posterior draw test is positive, not the anterior draw test. So this is to demonstrate that if there is a sag sign, you have to bring the tibia in the neutral position and then pull it to demonstrate the anterior draw test, and then push it backward to demonstrate the posterior draw test. In this particular patient, the posterior cruciate was damaged, though the tibia was coming forward, but there is a sag sign, it means tibia has already sagged posteriorly. There is another one, we can see it again, the posterior draw test. Doing posterior draw test in a case of posterior cruciate ligament tear, you can see tibia is sliding posteriorly over the femoral condyle. So it is positive here. The Latchman test is said to be more sensitive for the anterior cruciate ligament. The knee is now flexed 30 degrees and stabilize the lower end of the femur, and other hand will catch hold of the upper end of the tibia. With the stabilized femur, tibia is gently pulled forward on the femur, and then look for the translatory movement of the tibia on the femur. So this is the demonstration of the Latchman tests. Is to be done when the knee is flexed 20 to 30 degrees. There are two methodologies that you can follow. One is on the normal side first. Is flexed 20 degree. Stabilize the thigh, hold the thigh so that the weight is in your own hand now. And you are stabilizing when you are trying to push the tibia up, the femur will not go up, and neither there will be flexion of the knee. And then hold the tibia, thumb preferably closer to the joint line, and then pull the tibia up. Can you see this? Flex the knee 20 degree, stabilize the thigh. Stabilizing, we are using the word stabilizing, meaning you are carrying the weight of the thigh in your own hand, and you won't allow the thigh to go up when you are pulling the tibia forward, and then catch hold of the upper part of the tibia, thumb preferably closer to the joint, and then pull the tibia forward. See this, I am pulling it. And there is some laxity you can see. So there is same a little laxity on both sides, comparable, and so There is no anterior translation of the tibia over the femur. So this is the Latchman test method 1. Sometimes patient can be very heavy and very difficult to stabilize the femur, taking the weight in your hand. There can be another method that students may find it easier to perform. Just watch the video demonstration of that method. Latchman test. There are several ways. One is flex the knee 20 to 30 degree, stabilize the thigh with your another hand, and with my right hand I will be catching hold of the upper part of the leg. Again I will try to put my finger close to the joint and then I will pull it. It should be pull, stabilizing this one. Pull. I can do on both sides. This is one. But if the patient is bulky, obese, you can put your own thigh behind the knee of the patient and then you can repeat it. So it becomes easier for you to do it. So this is the second method that in some of the bulky patients can try and do it competently. So Latchman test in ACL tear, you can see a pathological one. Of ACL tear, anterior cruciate ligament is torn, and the Latchman test is here positive, very clearly seen. Now there is another test, PART test, to assess the integrity of the anterior cruciate ligament. It's called lever sign test. The patient is placed supine with the knee fully extended on the examination table, and the examiner places a closed fist under the tibial tuberosity of the affected knee, a little distal to the knee, and this causes knee to flex slightly. With the other hand, examiner will apply moderate downward force on the distal femur, and with this force the leg will go up. So in intact ACL, the patient foot will rise off the bed. But if ACL is ruptured, definitely the patient foot cannot be raised, and this is called the lever sign test. Put your fist under the tibial tuberosity, then knees flexed, and put downward pressure on the lower end of the femur. The foot will go up. And if it does not go up, there is a suspicion that the ACL is torn. Then we have to test the medial and lateral collateral ligaments. So Vares test is done for the lateral collateral ligament. Here the Vares stress is applied to the knee and it will produce pain over the femoral or the fibular attachment of the lateral collateral ligament or anywhere along the course of the ligament. We'll see how to do it. There is a demonstration for doing for the collateral ligaments. Always try to do on the normal side. Let us consider right side is the pathological one. We will do on the left side first. So there are again two tests that we have to do. Both will be doing on both sides. The steps are that lift off the leg from the bed, catch hold of the lower part of the leg, and for the Vares stress test must stabilize the medial side and then put a Vares force. I am putting the Vares force. It should be sustained force, no jerky movement, and watch for either the movement of the leg medially or joint opening on the lateral side. This is the test when the knee is in extension. Another is flex the knee 20 degree and then repeat it. Doing the Vares stress test by applying varus force and stabilizing the knee from the medial side. I will repeat on the abnormal side, considering the right side is the abnormal one. So first, when the knee is straight, I am doing, so when I am doing the varus stress test, I must stabilize the knee from the medial side, my hand catching hold of the lower part of the leg and making a varus force on it. There is no laxity. I will repeat the same when the knee is flexed 20 degree. So this is the varus stress test. So all these two methodologies has to be demonstrated. One, varus stress test when the knee is in extension, and the other when the knee is in 20 to 30 degree of flexion. So we can see some positive signs. This is a patient of lateral collateral ligament tear, and you can see it, the leg is moving towards medially, or the joint is opening on the lateral side. So this was the case of lateral collateral ligament tear. The valgus stress test then test the integrity of the medial collateral ligament. It is also done in two ways. One, when the knee is in extension, and the other when the knee is flexed 20 to 30 degree. And then apply valgus force in either the condition and see for the pain over the femoral and the tibial attachment or opening of the joint. We'll see the demonstration of how to do it. Very, very similar. So on the unaffected side, considering the right side is the pathological one, I will be doing on the normal side first. To test the medial collateral ligament, I have to put the valgus force here. So I will have to stabilize from the lateral side, leg off the bed, my hand catching hold of the lower part of the leg and applying the force which is the valgus force. And I will watch for the movement if the leg is moving laterally or the joint is opening on the medial side. And sometimes during grade 1 and grade 2 tear, you should look on the face of the patient for any pain. I will do on the abnormal side the same. So it is the valgus force I am applying, catching hold of the leg, the limb is off the bed, the stabilization is on the lateral side, and then putting the force, it is a valgus force, and watching for the movement of the leg which is going laterally or opening the joint. Both are negative here. Now we will see the other methodologies. When the patient is bulky, sometimes you need some other method. Carrying the weight in your own hand sometimes is difficult. So let us watch the technique of doing other methodologies. The third method also, which is very effective and less strenuous. Ask the patient to come on the edge of the table, knee on the edge of the table, where you can flex it, extend it, and then you apply on the lateral side. I am applying the knee extended and doing the valgus stress test. Same way I can do it, the varus stress test. See it like this also, varus stress test, valgus stress test. Flex it 20 degree, valgus stress test. Then varus stress test. It becomes easier. Again, let us see the technical demonstration of it. So what you can do is, you can take out the patient's leg with the help of your arm and forearm. Now weight is being stabilized. You have stabilized as well as taken care of the weight of the patient limb. It's not in one hand. And then you can do the same. I am doing it. So this is the valgus stress test when the knee is extended, and this is varus stress test when the knee is extended. I can repeat when the knee is flexed, the same. It is easy now. I can do like this also, but I want to see the whole of the front of tibia. Okay? So in this part, actually, the force was given by body from one side and by arm from the other side, alternative. So we'll see some pathological conditions where it was positive. Flex the knee 20 degree, and I am doing the valgus stress test. Then the varus stress test. I will repeat it on the other side, which is the affected side, 20 degree flexion, and this is the varus stress test, and this is the valgus stress test. You can see it, how it is moving. Okay. McMurray's test is one of the most favorite that is asked in the examination, and it is done to assess the medial and lateral meniscal tears. For the case of the medial meniscus, the flexion of the knee should be to its full range and externally rotate the tibia on the femur and extend the knee with a valgus force. For the lateral meniscus, it is same, but you have to internally rotate the tibia. So that is the only difference. And then we'll see the positive sign. What is the positive sign? Pain is felt by the subject, or if a click is felt by the subject or the examiner. For the lateral meniscus, again, knee should be flexed fully and internally rotate the tibia on the femur and extend the knee with a varus force. In the medial meniscus, it was the valgus force. So see the technical demonstration of it. For the McMurray's test, there are certain criteria. One is the step one I am going. So step one is the knee should be fully flexed. Preferably the heel should touch the buttock. So let us demonstrate for the meniscal tear of the medial side or medial meniscus. For the medial meniscus, full flexion of the knee, heel touching the buttock, and fingers over the joint line preferably. So this is joint line. Third step, external rotation of the tibia over the femur. Can you see this external rotation? Heel almost touching the buttock. For the medial meniscus, there will be external rotation that you will be doing. So see the external rotation of the tibia over the femur. And then 2 fingers over the joint lines, and then I will extend with a little of valgus force. Full flexion, external rotation of the tibia over the femur, fingers over the joint lines, and extend it. So these are the steps to do the McMurray's test for the medial meniscus. And there is a Thessal's test also. It is a dynamic reproduction of the joint loading in the knee. And theory behind this test is that the knee with a meniscal tear will produce the same symptoms the patient reported. In this test, the patient stands flat, footed on one leg while the examiner provides his or her hands for the balance. Patient flexes the knee 20 degrees and rotates the femur on tibia medially and laterally at least 3 times while maintaining this 20-degree of flexion. It is rotating the body almost over the tibia. Positive results are patient experiencing pain or discomfort on the medial or lateral joint line, or patient may also have a sense of locking or catching in the knee. So this is how it is done. Patient on one leg, knee flexed 20-degree, and then whole body with the femur rotates medially and laterally at 3 times. The patellar apprehension test, it is done. Patient when is supine, the knee is flexed to 30 degrees or knee in full extension. An examiner applies pressure from the medial patella to force patella laterally. Usually, the dislocation of the patella is on the lateral side. And the positive test is when the patient feels pain, patient may refuse to do this in anticipation of the pain, or patient tightens quadriceps muscle and forbids examiner to proceed. The patellar apprehension test is for the symptoms of subluxation of the patella. Applies grinding test and destruction tests. Grinding test is done to understand the integrity of the menisci, whereas Applies destruction test is done to understand the integrity of the collateral ligaments. So the grinding test is done when the patient is prone, the knee is flexed 90 degrees, and the rotation is done while a compression force is applied. In the grinding test, symptoms are reproduced and is torn. Destruction test is done to detect the ligament injuries. Here the rotation is repeated where the leg is pulled upward in place of pushing it downward, with the surgeon's knee holding the thigh down. The destruction test produces increased pain when the ligament is damaged. Thank you very much. Thanks a lot. Go to the video a few times to have the proper skill to develop, and keep on doing on the patients. For any queries and comments, you are most welcome and on this mail. Thank you very much.